everyone. This is Anne-Marie Hughes. I am a 10-year pancreatic cancer survivor, and I am joined here today with Dr. Igor Astsaturov from Fox Chase Cancer Center. Hi, doctor. How are you?
Hi, Anne-Marie. Thank you for the invitation. It's a pleasure. My connection with pancreatic cancer started back almost 10 years ago now, when my wife Elana was diagnosed with pancreatic cancer. Unfortunately, she died a year after. We could not help her despite best effort. And I remember through a personal journey with my wife how difficult it was to find clinical trials and find answers. New options. We had only 2 lines of chemotherapy back then, and for me, as a medical oncologist who coincidentally specializes in gastrointestinal tumors, that was personal tragedy, but also with Elena's journey through this disease. Not only I learned on my own skin how it is to be a caregiver of a loved one who suffers from pancreas cancer, but also I kind of palpably felt what is needed by the patients, and how limited we are in our understanding of the disease mechanism, and how limited we are in the number of treatment options. So when this happened, first of all, I connected with a whole bunch of absolutely fantastic people at PanCan, in the research community here in Philadelphia and around the globe. Launched a program, in fact, here at my institution, where I'm very honored to lead the Pancreatic Cancer Institute with my colleagues Iti Kukerman and Sanjay Reddy. So this program started due to a very generous donation of another remarkable individual, Chet Greenberg. She lost her husband, like I lost my spouse, back in 1990s. But her desire to change the way pancreas cancer is being treated and change the field with meaningful impact, with understanding of science and improving clinical care. So this is where we started about 3 years ago. And now we have a fledgling program that is now has recognized by American Pancreatic Cancer Foundation. We are a Center of Excellence. We launched a number of clinical trials, and this list is growing. We also launched research programs, received grants. Just this week, I received seed funding from the Hirschberg Foundation. We have launched a new clinical trial just in August, where we would learn the biology of pancreatic cancer in patients who undergo pancreatic cancer surgeries, and we will eventually dig into mechanism of why patients develop pancreatic cancer. This is really linked to understanding cancer origins, why certain diets, why certain chemicals that we expose to predispose patients to develop pancreas cancer. For instance, we launched a program very much inspired by great work by Gregory Betty at the University of Pennsylvania to understand better why pancreatic cancer likes so much to metastasize to the liver. So we started looking into the role of diet in that process, and also started looking into the risk of pancreas cancer in context of pancreas physiology, pancreas metabolism, and how this might be influenced what people eat. What is the connection of pancreatic cancer to diabetes? This is a triad of early pancreatic cancer diagnosis, a triad of weight loss, diabetes or glucose intolerance, high hemoglobin A1C, which is picked up by a blood test, and all of a sudden vague abdominal pain that may radiate to the back.
What about just simple blood tests that could be taken to at least get someone to the next stage of the correct diagnosis?
There's a very active pursuit of proteomics, specific proteins or glycoproteins that may be upregulated in pancreas cancer cells specifically, and not present in other tumor types or other normal cells of the body. There's a very active pursuit of genomics, some methylation patterns of DNA, the fragments of DNA that kind of gets spilled to the blood and can be picked up by very, very sensitive genetic tests. But I am very optimistic that we will come up with something very soon.
That's great. Is there something that you think you've learned and through our experiences with COVID and how the government propelled forward treatment for COVID?
All right. So COVID was a national and international global emergency, and we within months we started scrambling for answers and found actually quite effectively. If we utilize the same mentality and the same level of urgency when it comes to pancreas cancer, and this is the case rising. The cure rates are still egregiously low. We just crossed 8%, which is better than 5% 5 years ago, but still nowhere near where we have to be.
Right.
And I think the work that you do at PanCan, and we do in clinical trenches on a daily basis, I think that is very important. But events like this webcast, is to really raise awareness of people and the communities at large that this is happening. My neighbor, who lives right next door to me, was diagnosed and perished from pancreas cancer within a month. It's among us. It is something that is now affecting more and more younger individuals, and that's just a very troubling trend. Pancreas cancer is projected to be the third leading cause of death in less than 10 years from now. The spirit of collaboration and collective fight is what really needs to be in place for us to be able to find cures and answers quickly before we lose another 30,000-40,000 people a year who perish from pancreas cancer. And these numbers will unfortunately rise at high speed. This is what really is quite troubling.
That's why I'm doing this. And that's why you're doing this. So what, we kind of touched on some of this, but what excites you about the field today?
I'm excited about the opportunities that we have. I'm excited about finding people who are thinking like me. This is an urgency. We need to bring best science, best knowledge to the front line. We did somewhat better in understanding how we can treat patients who have localized disease. So now it is not a surprise to hear that, yes, we give chemotherapy before surgery for almost everybody with pancreatic cancer. This is the right thing to do. 10 years ago, it was not an absolute truth, but nowadays it has become probably the most commonly utilized standard of care, and also in many respects based on scientific evidence that pancreatic cancer cells can be detected in circulation early on, even at the moment of its inception. These floater cells that went to the circulation before you even do surgery. We can't just surgically remove this tumor from the pancreas because the chance it will come back is very high. We need to. The reason that the tumors come back as metastases is because they're already in the circulation. We can't just see them, but they are there. And then we start with aggressive chemotherapy. We add radiation again, based on an enormous amount of research and clinical data to show that these tumors tend to invade to the nerves. They go to the original lymph nodes. If we don't do radiation, there's a risk of local recurrence. And then only after we finish all of this, and the patient is a little bit beat up, but still in a good spirits, we go for surgery and take it out. And it's very satisfying to see them cancer-free years after they've been through the treatments.
It's a difficult cancer, and I wouldn't be here without people like you. And I'm very grateful. Thank you.
It relates to all of the clinicians who take care of the patients. And thank you for saying that.